Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review podcast, your on-the-go source for radiology board review. On this episode, I will be discussing in a question and answer format tumors of the central nervous system. This will be a multi-part series on central nervous system tumors. After I have released these episodes, I will make a downloadable study guide available on my website, theradiologyreview.com. So look for that in coming weeks. Without further delay, let's get into this episode. Let's start with this question. What are a few differences in appearance between astrocytoma and ependymoma within the spinal cord? A few things that should come to mind are that compared to an astrocytoma, an ependymoma of the spinal cord has a classic apical cap of blood and is often cystic in appearance. Additionally, if you are presented with an image of the spinal cord of an adult, you would favor ependymoma. In a child, you could see either an ependymoma or an astrocytoma. A syrinx within the cord would be more common with an ependymoma, and an ependymoma would more likely be central in location, whereas an astrocytoma would more likely be eccentric in location. Next question. All high-grade parenchymal brain tumors enhance. What low-grade tumors of the brain also enhance? The most characteristic low-grade tumors in the brain that would demonstrate meaningful enhancement are gangliogliomas and pilocytic astrocytomas. Gangliogliomas and pilocytic astrocytomas are notable that they are low-grade tumors that may enhance despite being low-grade. Next question. What is the classic imaging appearance of a pilocytic astrocytoma? Let's keep this concise and simply say that the classic imaging appearance of a pilocytic astrocytoma is a cystic mass with an enhancing mural nodule. Next question. What lesions are classic for crossing the midline of the brain? Now for this question, consider both tumors and non-tumoral entities. What lesions in the brain are classic for crossing midline? Top considerations that you should consider for lesions that cross midline include glioblastoma, lymphoma, multiple sclerosis, radiation necrosis, and a meningioma of the falx. That is not an all-inclusive list, but those are top considerations that I would have in mind for the ABR core exam and other radiology examinations. Next, if you see bony reaction or thickening of the skull adjacent to a mass, what is the significance of that finding? Typically, bony reaction surrounding a mass denotes that the mass is extraaxial, and that is the answer I was looking for, is that if you see bony reaction or thickening of the skull adjacent to a mass, that typically means that the mass is in an extraaxial location. Next, what are two masses that are not extraaxial that can nonetheless cause local bony reaction? Two masses that are not extraaxial that can nonetheless cause local bony reaction are ganglioglioma and a DNET, D-N-E-T, which stands for dysembryoplastic neuroepithelial tumor, D like dog, net. And DNETs, when in a cortical location, which is typical, may remodel the adjacent skull. Next question. What are other signs besides bony reaction on imaging that denote a mass is in an extraaxial location? A few things you can look for as evidence that a mass is in an extraaxial location include seeing a CSF cleft around the mass, a cerebrospinal fluid cleft around the mass, seeing displacement of subarachnoid vessels by the mass, seeing an expanded subarachnoid space around the mass. If you have a broad-based dural lesion with a tail, such as a meningioma, and if you are able to identify gray matter distinctly located between the mass on one side and the white matter on the other side, those are all signs that a mass is extraaxial in location. Next, what are common cortically based tumors of the brain? There is a simple mnemonic for this, which is dog, like man's best friend, a dog, D-O-G. The mnemonic DOG can tell you about common cortically based tumors of the brain. D again stands for DNET, which is a dysembryoplastic neuroepithelial tumor. O is for oligodendroglioma, and G is for ganglioglioma. Note that cortical tumors and cortical metastases may be occult on a non-contrast CT or MRI and may have very little surrounding edema. So for these cortical-based tumors, contrast-enhanced imaging can be key. Next, what are some brain tumors that are classically multifocal on imaging? The first thing that I think should come to mind are brain metastases. These would commonly be multifocal on imaging. Other tumors that are classically multifocal include lymphoma. Glioblastoma certainly can be multifocal, and gliomatosis cerebri. Note that gliomatosis cerebri is often low-grade and may therefore not enhance, but may manifest with indistinct margins or blurring between the gray and white matter on CT scans. Note also that some tumors may seed in a multifocal manner, and these include things like medulloblastoma, ependymoma, glioblastoma multiforme, and oligodendroglioma. Next, what is SACHMO? If you haven't heard of SACHMO, that is SATCHMO, or sometimes SATCHMOE, SACHMO. What is SACHMO? Now, I am asking you this question because there are mnemonics like SACHMO that many radiology residents know, but the key is, do you remember what the point of mnemonics are? And for SACHMO, what is this mnemonic useful for? The answer I am getting at is that SACHMO is a mnemonic for cellar and paracellular mass lesions. Let's go ahead and get into this. So what does SACHMO stand for? Go ahead, hit the pause button. What does each letter of SACHMO, SATCHMOE, stand for in terms of cellar and paracellular mass lesions? Let's go through it. S is for sarcoid. A is for aneurysm or adenoma, or, and I don't like this one, Rathke's cleft cyst, meaning the A after the R, Rathke's cleft cyst. That's kind of a stretch. But again, A can stand for aneurysm, adenoma, and Rathke's cleft cyst. T is for teratoma. C is for craniopharyngioma. H is for hamartoma, hypophysitis, and histiocytosis, such as with Langerhans cell histiocytosis, and hypothalamic glioma. That is 4 potential H's. M is for meningioma. O is for optic nerve glioma. And finally, the optional E that some people throw on is for eosinophilic granuloma. I do find this to be a useful mnemonic, which is why I'm reviewing it. And if you need to still commit this to memory, go ahead and look it up and study SACHMO. Next, What are the top differential considerations for lesions that show restricted diffusion on diffusion-weighted imaging for the following locations? So first, think of top considerations for lesions that show restricted diffusion in the supratentorial location, then cerebropontine angle, then temporal horn location, and finally in the pediatric posterior fossa. Let's start with supratentorial. What are top differential considerations for lesions that show restricted diffusion in the supratentorial region? And I am not talking about stroke for any of these. For the supratentorial location, I would think of lymphoma or abscess. Now think cerebropontine angle. For the cerebropontine angle, I think the top consideration should be an epidermoid cyst. Now think temporal horn. In the temporal horn location, a lesion with restricted diffusion should make you consider HSV encephalitis, herpes simplex virus encephalitis, and finally, pediatric posterior fossa. And for this, I consider the top differential consideration a medulloblastoma. Next question. What are the most common primary brain tumors that calcify? Oligodendroglioma is most classic for a calcified brain primary malignancy. I think that should be number one in your mind, oligodendroglioma. However, astrocytomas can calcify, and because they are much more prevalent than oligodendrogliomas, you would actually see more calcified astrocytomas in real practice, although the most classic for something like a board exam would still be oligodendrogliomas. Next, what brain tumors are classically bright on T1 weighted images? For brain tumors that are T1 bright, first I would consider melanoma metastases, and then I would consider hemorrhagic metastases, which can include metastases from melanoma, renal cell carcinoma, carcinoid tumor, thyroid carcinoma, choriocarcinoma, and others. For a T1 bright tumor in the brain, I would also consider dermoid cysts. Additionally, a T1 bright mass could also represent cholesterol within a colloid cyst. Next question. What are classic imaging features for Turco syndrome? That's Turcot. I think it's pronounced Turco. What are the classic imaging features for Turco syndrome? Turco syndrome is most characteristic of brain tumors, which can most commonly be glioblastoma or medulloblastoma, which go along with GI polyps. So if you see gastrointestinal polyps and they show you a brain mass that looks like it could be glioblastoma or medulloblastoma, this should cue the potential that this patient has Turco syndrome. Next question. What should you think of if you see an intensely enhancing homogeneous solid mass with restricted diffusion in a periventricular location in a patient who is immunocompromised from AIDS or post-transplant state? Whenever you are presented with a question asking you about a brain lesion in a patient who is immunocompromised, you should always consider primary CNS lymphoma, and you should also consider toxoplasmosis. Differentiating between lymphoma and toxoplasmosis in the CNS in an immunocompromised patient is a classic scenario that is often tested. Remember that CNS lymphoma is hot on a nuclear medicine thallium scan, that is TH, thallium scan, whereas CNS toxoplasmosis is not. Both can show uptake with FDG PET-CT, and I believe I have reviewed this fact now maybe 4 or 5 times on podcast episodes, but it keeps coming up because it's an often tested concept. So If you see an intensely enhancing homogeneous solid mass with restricted diffusion in a periventricular location in a patient who is immunocompromised, think primary CNS lymphoma versus toxoplasmosis. And remember that CNS lymphoma would show uptake on a thallium scan, whereas toxoplasmosis would classically not show uptake on thallium imaging. Next question. An infratentorial cystic lesion with an enhancing mural nodule is most classic for what entity in an adult and what entity in a child? The answer I am looking for is that an infratentorial cystic lesion with an enhancing mural nodule in an adult would be most common with hemangioblastoma. And with hemangioblastoma, this should always cue the potential that this patient has von Hippel-Lindau syndrome, especially if you see multiple hemangioblastomas. On the other hand, in a child, an enhancing mural nodule within a cystic lesion would be most classic for pilocytic astrocytoma. Next question. Intraventricular tumors in an adult classically include what entities? Intraventricular tumors in adults classically include things like subependymoma, central neurocytoma, a xanthogranuloma, a colloid cyst and meningioma, and other, perhaps less classic entities. The last series of questions I will present in this episode all have to do with intraventricular masses. The first is if you see a non-enhancing intraventricular mass, this should make you think first of what entity? The answer to this question is a subependymoma. Subependymomas are notable for their lack of enhancement and typically appear as a circumscribed non-enhancing mass at the foramen of Monro and fourth ventricle. Next, what is the top intraventricular mass in the 20 to 40-year-old population? The number one intraventricular mass in a young to middle-aged adult is a central neurocytoma. Central neurocytomas can have a Swiss cheese appearance, meaning that they can have multiple internal cystic spaces, and central neurocytomas also may have robust calcification and often arise from the intraventricular septum. Next, if you see a mass with restricted diffusion that arises from the choroid plexus, this should make you think of what entity? A mass with restricted diffusion arising or involving the choroid plexus should make you think of a xanthogranuloma. That is XANTH, xanthogranuloma, which is a benign and typically incidental mass of the choroid plexus. Next, what intraventricular mass is most classic in the setting of death from acute hydrocephalus? This is also a classic question that you definitely need to be aware of, and something that you should also be aware of when on call. What intraventricular mass is most classic in the setting of death from acute hydrocephalus? The answer is a colloid cyst, and colloid cysts can appear as a round, dense mass located typically at the foramen of Monro that can cause acute obstruction of the foramen of Monro, which can cause acute hydrocephalus and, in extreme cases, death. So remember that a colloid cyst has this potential to cause acute hydrocephalus, which can have severe consequences to patients. Last and final question for this episode. What is the most common location for an intraventricular meningioma? The answer is that intraventricular meningiomas are most common in the trigon of the lateral ventricle, and in fact, about 80% of intraventricular meningiomas are located within the trigon of the lateral ventricle. that concludes the questions and answers for this episode. I hope this is helpful for you. Thank you so much for listening to this podcast. Please rate this podcast 5 stars and leave a review on your favorite podcast directory. Also, consider sharing this podcast with medical students who may be interested in radiology or trainees completing their intern year who are either interested or entering radiology in the near future. I appreciate the support from each of my listeners throughout the world, wherever you may find yourself listening to this podcast. If a radiology board exam is in your future, remember that you have to study really hard to succeed on radiology board exams. So prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.